This is one interesting and challenging case in which this is the patient in which you can see there's a hard mature cataract, and as the fundus was not visible, so a B scan was done and which appeared to be having a normal posterior segment. This is the other eye which had been operated few years back and was functioning fine. This is the fundus of the other eye which is having tessellations which are age related changes. And this is where we start, and this surgery video has been sped up by 1.5 times so as to expedite the process and keeping it interesting. Making an incision which is temporal about 170 degrees, which is the steep axis, and aiding in reducing the amount of astigmatism, I usually make an incision on the steep axis. Staining the capsule with the trypan blue dye, and I must mention that this patient was pretty apprehensive, and the signs which we can see in these patients are they are not very easy in their behavior, and they keep on talking, they keep on asking for favors, and that is something which gives away their apprehension. So as we can see, the patient is unable to keep the eye stable, and this is also a reflection of these patients who are just unable to keep the eye stable even on repeated requests. So here the rhexis has little runoff, so I replenish the anterior chamber with viscoelastic gel, and we will see that the capsule is so fragile that the portion of the capsule simply ripped away. And interestingly, these capsules are so fragile that when even if you reach to the periphery, they usually don't tug on the zonules, rather they tend to simply tear away from the attachment wherever the zonules start. So even if these capsules that rhexis run off, it doesn't damage the zonules. It's a large rhexis, and the problem with large rhexis is that the nucleus will simply pop out into the anterior chamber during the emulsification, and there's nothing which will stabilize it. This is a new neosonic tip which I have been using, and this has a flared tip and a constriction and a narrower body which constricts or restricts the amount of fluid flow, so you can have a higher vacuum holding power. And going for a burst mode, as we can see, the burst mode usually releases lot of bubbles which are trapped in the needle tip, and again applying for a burst mode to get good purchase, as this is supposedly a thick nucleus, and then causing the first chop which apparently is incomplete. Aspirating the vacuoles or the bubbles which have formed, and then attempting to chop this smaller chunk of the nucleus by purchasing and repurchasing so that to get a full thickness chop here. And these nucleus, because they are bulky, one has to emulsify quite an amount, and interestingly they have least amount of cortex. So once the nucleus is delivered, or part of the nucleus is delivered, there is nothing to cushion or to keep the nucleus in place, especially if the rhexis is too big. And this is what we will see today. The nucleus will simply dance into the empty bag which has no epinucleus or cortex, plus it's a large rhexis which allows the nucleus to bump or jump out of the bag. So half of the nucleus has been emulsified, and once I chop the nucleus, I switch on to pulse mode, which provides me interrupted power and also helps in cooling and reducing the repulsion of the pieces. Now this situation where the nucleus is not stable and is jumping up and down, and also not stable in rotatory axis, it's better to align the nucleus rather than using the same tools to align it and emulsify it. I find this safer because this nucleus will be wild in behavior. So you have to have control by impaling the needle on the nucleus so that at least the needle hold will keep it stable. Again burying it using some power, and if you will notice, I have been rotated the nucleus in such a manner that the piece which I had chopped off was actually attached to the needle tip. So this helps in keeping the nucleus stable and also provides me hold over the piece which I want to emulsify. On the other hand, if I would have chopped in the other direction, it would not have allowed me such a convenience. Holding and chopping and also retaining the chopped piece onto the tip so that it can be simply emulsified. So you want the smaller piece to be retained onto your tip so that you can simply proceed to emulsify after the chopping. The nucleus has been removed, and what is left behind is just some amount of cortex or any small amount of splinter of the nucleus. Till now the surgery is safe, and only issue would be how the cornea is going to behave the next day, because these nucleus which are chunky require a lot of power, and also the pieces, they are large if the chopping is done in a smaller way, so that the nucleus pieces may touch the endothelium and contribute to the next day keratitis. This is a negative aspheric orolap lens, single piece hydrophobic, being implanted into the bag. And I like this lens because it is negative aspheric, so it gives some amount of extended depth of focus to the patients, and I have seen patients having good vision out of this lens, and exceptionally good vision in few patients for near, and that is what I like about this lens. The IOL is being dialed into place. Large rhexis requires that one has no visibility of the rhexis border, so you have to dial the haptic by intuition. Going on to aspirate the viscoelastic gel, and along with that whatever flimsy amount of wisps of cortex are left behind will also be removed. I am also keen to observe the posterior fluid wave which allows the viscoelastic trapped behind the IOL to be flushed out, and this may come at any point when you are irrigating, aspirating. The viscoelastic gel has been removed and anterior chamber is being inflated. However, because the incision site is little leaky, it is better to hydrate the wound so that the wall becomes better functional. So at times only one side hydration may work, but at times it is required that both the sides should be hydrated well. And we can see this is the first day post-op image, which shows a nice clear cornea and patient had good visual gain, and this is the fundus photograph which was not visible earlier. Thank you.